from 1 day to 100 years, anytime they can just suddenly die like that. It is cardiac arrhythmia. Suddenly, it causes cardiac asystole and Brugada syndrome. Brugada syndrome can be detected sometimes if we have detected 3-4 patients, screening patients, and you have to treat them, treat the patients, Brugada syndrome patients. We should be very careful. There is no specific treatment. It's a channelopathy. The defect is in the sodium channels in the myocardial cells. It's a genetic disorder. There is no specific cure, but if you take care of their sugar, BP, you may prevent the complication. But sudden cardiac death syndrome, nocturnal death syndrome, you must have heard of these different funny names. Sudden cardiac death syndrome, nocturnal death syndrome. Patient is absolutely fine. He slept after dinner, morning he is no more. So these are the genetic diseases that can present in the heart. And again, diet, you have to inquire about the diet of the patient. Many times we Indians, we eat more salt than it is required, than it is consumed by the Westerners. We are more salt eaters. This is one of the reasons why Indians. I wrote one article. It was published in the newspaper 7-8 years back. The topic was why Indians. That's all. So it attracted a lot of people. Many people called me appreciating my topic. Why Indian? That was only topic. Why Indian? And nowadays, apart from your clinical examination history, inspection, palpation, percussion, so without ECG, without 2D echo, you're not able to diagnose it. So ECG, X-ray, ultrasound, 2D echo is now considered a part of the extension of the clinical examination. I wrote another article on fifth limb of the examination, fifth limb. So if you consider inspection, palpation, percussion, auscultation as 4 limbs, and the clinical examination is a dying entity. We are not bothered about examining. Anybody coming with chest pain, you just write invest. Anybody coming with headache, you are writing CT scan directly. So we are forgetting the good old time-tested clinical examination. As a senior, I am worried. The clinical examination, you have to be a clinician first. A clinician is a respected. If you can diagnose clinically, there's nothing like this. Of course, I'm not against investigation, but then you take only whenever it is necessary. But now, since these new things have come up, now ECG, chest X-ray, ultrasound, and 2D echo. These 4 are considered to be fifth limb of the clinical exam. They are part of the extension of the clinical. This was my topic published in one of the journals. Dying clinical medicine. Okay. So same thing, we have a cardiac manifestation of systemic illness also. Whenever there is some disease elsewhere, a patient will come with heart problem. Actually, this is not the beginning of the heart problem, but the disease is elsewhere, and vice versa also. The cardiac disease patient can come with something else. Disease elsewhere can come with cardiac looking like symptoms. Example, suppose a patient comes to you with stroke. We were discussing stroke yesterday. Patient comes with stroke. We are thinking stroke and he is admitted in neurology. Actually, there is an atrial fibrillation. There is a thrombus in the left ventricle. The disease is in the heart actually. There is no disease in the brain. The cardioembolic stroke. So, a disease in the heart may manifest like a stroke and vice versa. For example, atrial fibrillation. Patient comes with atrial fibrillation, irregular heartbeat. We think that there is a heart-related disease, but in fact, this patient is having hyperthyroidism. So if you treat the hyperthyroidism, your atrial fibrillation might get controlled. So what are the causes of atrial fibrillation? Can you type? What are the causes of atrial fibrillation? We'll talk about those things later, but just a question for you today. Causes of atrial fibrillation. Okay, you can remember one word, thrill. 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 Thyrotoxicosis. hypertension, rheumatic heart disease, ischemic heart disease, lung infection, and lone atrial fibrillation, L-O-N-E, lone. Lone atrial fibrillation is idiopathic, commonly seen in old people. If you remember this word thrill, there are many causes of atrial fibrillation. These are just a few. CHRILL, thyrotoxicosis, rheumatic heart disease, ischemic heart disease, lung infection, lone atrial fibrillation. So these are the causes of atrial fibrillation. And same thing can happen if somebody coming with pericardial effusion, breathlessness. When you take an X-ray, there's a big fluid around the heart, pericardial effusion. So in fact, the problem is tuberculosis. Heart is normal, but it is causing pericardial effusion because the underlying disease is tuberculosis. So this way and that way, both are positive. So diseases elsewhere can manifest in the heart. Disease of the heart can manifest in as some other diseases. So one word about the prevention. In cardiovascular diseases, prevention is very important. All as a primary and secondary prevention. Prevention of the risk factors is the main cornerstone of the treatment. If you prevent the risk factors, reversible or modifiable risk factors, they are modified. Age you cannot change, family history you cannot change. But reversible, like smoking you can stop, BP you can control, sugar you can. So the reversible risk factors can be reversible, controlled. And this is all related to heart. Vascular system, we have now talk about vessels, vascular system, cardiovascular disease. Because these are vascular, they contribute a lot to the homeostasis of all the organs. Your liver is functioning well, your kidneys function well, because the arteries supplying that particular organ are healthy. So right from this small capillary, capillary is a monocellular structure, one single layer of epithelial cell. Of course, there is a small basement membrane, but the single layer is a dynamic function. That is the part that the capillaries are the one which supplies blood to each cell of your body. And the human is just enough for the RBC to squeeze through. What is the size of the RBC? 7.2 microns. The capillaries, human size also is 7.2 micron. And the capillaries, if the capillaries are, everything is all right, heart is all right. If there's any defect in this peripheral vascular bed, again you will have problems. And if you come to bigger arteries, they're made up of thick walls. There are three layers, you know, intima, media, and externa. The three layers of the arteries. So they carry the blood. Not only this, the blood viscosity also is important. It should be in a proper viscosity. It cannot become thick, or it cannot become very thin. So thick means polycythemia or any other viscosity. Polycythemia, you have more viscosity. You get blood clot. If there is severe anemia, or if there is any other clotting defect, you may get bleeding. So this is a general introduction to the cardiovascular system today. Tomorrow onwards, we'll take up each disease and we'll try to cover up maximum in this limited time for you to be exam ready. I think we'll close here. I'll take up a couple of questions. Anybody is interested in asking questions, you can just type in the box and we'll take up a couple of them. Yesterday there were about 10, 15 questions.
I have a question. After how many days or how much time of rheumatic fever takes cardiac CVS?
Yeah, it is usually 10 years. If the rheumatic fever is not detected, sometimes they may be silent also. Patient even may not remember, because it presents with just the fever for throat pain and fever and mild joint pains, which will mimic any viral disease these days. So these rheumatic fevers to manifest in the cardiovascular disease or valvular, to get involvement of the valves of the heart, it will take at least 10 years.
What's the prognosis of second time LAD center?
Second time?
LAD center.
If it is identified properly and stenting done, once you do the stent, your circulation is re-established, your flow is re-established. It all depends on when you are doing this stenting. If it's already damaged, there's a big thing, so you're only giving a partial relief. But if you are doing that's a very important, very good question actually. See, whenever somebody gets an acute MI, if they come within 1 to 3 hours, we do primary angioplasty. Primary angioplasty means we do emergency, we take up the patient to do angiogram and then put a stent immediately. So there you will not cause any damage to the myocardium. Versus other patient coming after 3 hours or after 12 hours, where enough damage is, there is a myocardial infarction. Even if you put stenting, you have to put stenting to prevent further damage. You have to put a stenting, but it's not as normal as you are doing on a patient who came less than 3 hours window period to you. Second time, third time, stenting also no problem. You should do in a proper time and properly. Okay, if there are no questions, we'll meet again tomorrow. See you. Thank you. Good night and take care and bye-bye.
The person diagnosed with pre-vessel disease, 99% are. A person diagnosed with pre-vessel disease, 99% RCA, 90% LCD,
LAD.
LAD and A normal, but patient shows no symptoms. What should be treatment? Angioplasty or only medication?
Can you repeat again? Your RCA, right coronary artery is 99% blocked. Then
LCD,
LAD.
and
LAD
90%.
LAD 90% and LCS.
It's very normal. RCA is 99% and LAD is 90% normal. But patient shows no symptoms.
What is 90% normal? 90% block. It was 99%, 99%, RCA 99, LAD, put stents in LAD and RCA. Because the left main artery, coronary artery is normal, you can put two stents. There is no need for sending the patient. You have not mentioned about what is the status of LCX, left circumflex artery. If left circumflex artery is normal, you can put 2 stents and successfully treat your patient. Any more questions? If there are no questions, we'll close here. Thank you.